talk about interventional oncology, something dear to me, and radioembolization. We're going to talk about patient selection and some angiography. Okay, so here's the overview of the talk today. We're going to talk some of the basics of Y-90 radioembolization. Really boils down to, and kind of what Mikhail was talking about also, is optimal candidates. You really want to make sure you're selecting the right patients so you have good outcomes, you're not causing harm. And then we're going to talk about the steps that are involved in radioembolization, because it is there are multiple steps, and that starts in the pre-procedure area. Then when we actually see them in the angiography room, so as far as mapping and some of the issues we do on the day of the mapping, including injecting technetium-99 MAA. Then there's the actual treatment, and then post-procedure follow-up, and then we'll end with some cases. So overall, the rationale between intraarterial therapies, and that's just not radioembolization, but it's also chemoembolization, bland embolization. Basically, these liver tumors, they preferentially receive their blood supply from the hepatic artery, whereas the normal liver receives its blood supply from the portal vein. So if we thread a microcatheter into the hepatic artery and we inject something, it will preferentially go to these tumors and not affect the normal liver. And so in this way, we can selectively deliver our anti-cancer treatments. And when we're seeing these patients and we're discussing with them in clinic before we treat them, we are kind of temporizing our outcomes in some level, because it is palliative treatments. We're not curative. Curative treatments include surgery and ablation. But here, intraarterial therapies, and again, that's chemoembolization or radioembolization, we're trying to keep the tumor at bay, improve survival, and have low toxicity, but we aren't necessarily curing. So a picture tells 1,000 words here. This is a microcatheter that has been threaded into the right hepatic artery, and you can see the hepatic artery branches, and you start to see all these little blushes. And so this is all the hypervascular tumors here in the right lobe of the liver. So you can understand, whatever we inject here, you're going to get very high concentrations in these tumors while not seeing the normal liver. So radioembolization came along because we know radiation does affect tumors, and that has and so we do actually collaborate with radiation oncology, because they also will radiate tumors in the liver. The issue is that the liver, normal tissue, is quite radiosensitive, and so radiation oncology has been limited in the past by the toxicity profile, but their technologies are also getting better as far as how well they can target tumors and spare normal liver. But where we have a benefit over radiation oncology is we depend on that blood supply, that blood flow. And when we inject, we can actually get much higher radiation doses into those tumors than they can externally, because they are limited by the tissues that the beam has to go through. Whereas we do intraarterial therapy, intraarterial radioembolization, and so therefore we are not limited by that. And a little bit different from bland embolization or chemoembolization, where embolization is a big part of what the treatment approach is, where you're cutting the blood supply and that kills the tumor. With radioembolization, it's really just depositing the radiation beads in the tumors, and the radiation locally is what does it, rather than blood. So, if you're doing radioembolization procedures and you're treating these patients in interventional radiology, it's really important now that you follow patients longitudinally. You're seeing them in clinic beforehand. You're talking about the procedure, you're assessing things, and then you follow them after. And the follow-up of the after is not only to know that the patient did well, but it's also to show you, and you can perfect your skills as you see what works, what doesn't work, how patients do. So the optimal candidate for radioembolization, and this is also for chemoembolization also, is they're not a curative treatment patient, so ablation or surgery. Liver only or liver dominant disease, that's very important, because some of the tumors we treat, such as metastatic colorectal cancer, they come from other places in the body. And if there's a lot of tumor outside of the liver and we're just treating the liver, we've come to realize that doesn't really benefit overall survival. So you want to select patients where possibly chemotherapy has shown that really the liver is the only problem, and that's what you're approaching. And then These are all the other things that we assess when we see these patients in clinic, and that includes performance status and liver function, because those are the really important things that will limit us with toxicity. And because any treatment we do has toxicity, and we want to make sure the patient has the ability to handle that toxicity, or else we're not really helping. Even if the tumor improves and the tumor goes away, but the patient has very bad encephalopathy or ascites, that doesn't really benefit the patient. And so here's the relative contraindications for the patients. Again, a lot of the similar things that we talked about and what makes a good candidate for radioembolization. And again, it's performance status and liver function. But some other things that, like again, we kind of mentioned, is that if the patient is dealing with encephalopathy and intermittently, when you do some kind of treatment to the liver, that's going to get worse. And same with ascites. So these are things that you don't really see in numbers, and this is why you really have to assess patients in clinic. Of course, right now we're doing a lot of virtual clinic, but it's very important to see the patient face to face and really talk about things. All right, so let's talk about radioembolization, and we're talking about Yttrium-90 here, which is a pure beta emitter. It's important to know the half-life, which is about 3 days, because when you're talking with patients, they're often wondering, how long does this radiation stay in my body? So half is gone in 3 days, but 10 half-lives is actually 1 month. So there is some radioactivity for up to 1 month, but it is not for months and months. And the important thing also is that the tissue penetration in the liver is only a couple millimeters. So people can be in the same room as somebody who had radioembolization, and they should not be affected. When we started, we had a lot more restrictions on how we were treating these patients and how they had to be segregated from other people. We've really gotten away from that. Just what I tell my patients is, don't hold any, children or babies next to your right side. Other than that, you can really, really there's no radiation effect of people around. And then just to be aware, there's 2 products out there for radioembolization. There's Surspheres and Theraspheres. And they're actually the same Yttrium-90, so the same tumoricidal approach. The only issue with them is how they're manufactured, and that is that the Surspheres actually have about 40 becquerels per microsphere, versus Theraspheres has about 2,500 becquerels per microsphere. So for the same prescribed activity, that's how we determine what we're going to inject, you're actually going to have more particles with Surspheres to get the same activity that you would, and you'll use less particles with Theraspheres. So that can come into play in certain technical aspects, as far as if you're trying to just treat a segment, or maybe you're trying to cover a large tumor, you may choose one or the other. But in the end, if you're comfortable with using one or the other, you can pretty much do what you need to do. And then the other difference between them is just how they were approved. Surspheres was approved for metastatic colorectal cancer. And so there's a lot more data probably with metastasis and colorectal cancer, versus Theraspheres got a humanitarian device exemption for HCC. So there's more data with HCC. That being said, people are using both products for all kinds of tumors and that are treated. And the only other issue is the humanitarian device exemption does require you to have an IRB approval for use of Theraspheres. So let's talk about the steps now that go into radioembolization. And here are the steps here. We're going to go through each one. So pre-procedure, and this goes for all interventional radiology procedures, it's very important to review the imaging you have before you start your procedure. You should know in your head already what approach you're going to take, what issues you might face. And so you want to have really good imaging and recent imaging when you evaluate these patients. And part of that is you're going to look at the blood vessels. You're going to see where they're going. And so when you do your angiogram, if you're going to have aberrant vessels, you'll probably know that. But a good angio can actually show you things that a CTA may not show. And also you're going to look at where the tumor is, how vascular the tumor is, and that's going to tell you basically what's your treatment approach. Are you going to do a segmental infusion? Are you going to do a lobar infusion? Are you going to bring the patient back maybe to treat different areas? So you really want triple phase CT or MRI, and we also use these images to get 3D volumes. So you may have a 3D lab that is able to make these images for you, or you need to make them yourself, but these go into the dosimetry and how we decide what kind of activity we're going to infuse. And so you want total liver volume. So here we have a right lobe and left lobe, And then here we've circled the tumors, and we have tumor volumes also. So these go into the equations we use to figure out what the dosimetry is that we're going to want to inject. So it's very important to have good imaging and recent imaging again. And you know, a lot of times it's triple phase CT or MRI. We are treating some colorectal cancer patients, and those patients, their tumors aren't necessarily vascular. So in those patients, a PET CT may actually be more important. Maybe in colorectal cancer, cholangiocarcinoma, melanoma, PET CT may give you a better assessment of what the tumor volume is. Especially because a lot of these patients are on chemotherapy and then they come to you, and dead tumor and active tumor can look the same. So very important, and maybe even more important when you're establishing your Y-90 practice, so that you can show your clinicians, the referring clinicians, that you've treated the tumor, there's activity, and then that activity goes away. All right, so you've assessed the patient, you've looked at the imaging, and you've brought them now for angiography. Very important here, you want to do a thorough mesenteric arterial evaluation. You can go transradial, you can go femoral, but you really want to look at all these arteries: the superior mesenteric artery, the celiac artery, the left gastric artery, and then you get into the liver, looking at the common hepatic artery, right hepatic artery, and left hepatic artery. Maybe if you know you're just going to treat a very segmental area in the right lobe, maybe you don't need to look at all these arteries, but a very thorough examination would have all these. You want to use high flow microcatheters, and then cone beam CT is something that, you know, was relatively new, maybe half a decade ago, and now it's really standard of care and really is helpful in these patients. So these are some of the blood vessels you want to make sure you're aware of. You may or may not see all of them, but it's always good to have an idea of these when you're looking at liver-directed therapies, intraarterial therapies, and we'll go through each one. So the first one is the gastroduodenal artery. So you have your celiac artery, you have your splenic artery, you have your common hepatic artery, and then the gastroduodenal artery usually comes off inferiorly like this, and that is the distinction between the common hepatic artery and the proper hepatic artery. And why is that important? Because it's usually, you know, very near the liver vessels, and this blood vessel does not go to the liver. It goes to the pylorus, it goes to the duodenum. So you want to identify this and identify how it relates to your right and left hepatic arteries. You know, one other artery I should mention are supraduodenal branches. Sometimes there are very small branches that just come down, and really that has been problematic for me in my time of treating patients. Not really the GDA, you can always see the GDA, but small supraduodenal arteries can come down and feed the duodenum, and if radiation beads go into that, you can get an ulcer, which has a lot of morbidity. So that's why I always do a cone beam CT now whenever I put my microcatheter where I'm going to inject from, and I really study it to make sure I don't see any of those vessels. So the cystic artery often comes off the right hepatic artery, and that supplies the gallbladder and the cystic duct. And, you know, born off of chemoembolization, with radioembolization also, we don't worry that much about the cystic artery. Anecdotally, I've seen people embolize this with like a coil so that their radioembolization beads don't go there, and that's the patient that gets cholecystitis. So we really, if we can, we avoid the cystic artery, but at the same point, we know radiation beads going to the gallbladder doesn't necessarily give you cholecystitis in every case, so we don't worry about it. Replaced right hepatic artery, that's the most common anatomical variant to the liver, and it comes off the superior mesenteric artery, and usually supplies the entire right lobe in about 12% of cases. The right gastric artery, this is an important artery to identify, usually comes off the left hepatic artery, but you can see it come off, it can also come off the common hepatic, proper hepatic, or gastroduodenal artery, and this supplies the lesser curvature of the stomach. It anastomoses to the left gastric artery, so you really want to be aware of this, again, especially because it's coming off of usually a intrahepatic branch, left hepatic artery. So this is one we would often coil. You can see they've coiled the GDA here. This is one you might coil if you're doing a left hepatic arterial branch. It's important to look, what is your first vessel of reflux? So if we put a microcatheter out here into the right, it wouldn't necessarily make sense that you have to coil the left hepatic because it would reflux and maybe come to the GDA, but if it was going to come and reflux into the left, you might actually coil that. So you always want to be aware, what is your first vessel of reflux? And then the replaced or accessory left hepatic artery, which comes off the left gastric artery, again, about 15% of the time, you want to be aware of this variant. And lastly, the falciform artery, it's this very typical artery which kind of comes, outside the liver distribution. And where this vessel is going is actually the anterior abdominal wall, so near the umbilicus. So the only issue with that is if the radiation beads go there, you can actually get a radiation-induced ulcer around the umbilicus or the anterior stomach wall. All right, so once you've done your mapping angiography and you've looked at the blood vessels, this is where we inject our technetium-99 MAA. So this is our test dose of radiation, so to speak. And that's because this MAA is a surrogate for what the radioembolization microspheres where they will go. And so after that, they will go to nuclear medicine, and you'll either get planar imaging, or a lot of people will move to SPECT CT, gives you a little more anatomic detail. And from that, you would get a lung shunt fraction. So you want to perform this relatively soon after you've injected your MAA, because now we're not talking about Y-90, we're talking about MAA, which is a relatively short half-life. And you are looking for extrahepatic deposition, although I would say anecdotally, you will not necessarily see this. The sensitivity of these images may not show you the extrahepatic distribution of the MAA. You really want to look at your angiograms. And then as we get more refined with our dosimetry, this will show you how much of what you're injecting is going to the tumors versus the normal liver, and that's the T to N ratio. And so this is an area of research in radioembolization and interventional oncology where we're trying to refine what we're injecting, that we're getting good treatment effect, but not affecting normal liver. And so by doing ROIs on the tumor versus the normal liver, you can get a T to N ratio, and that would come off of a SPECT CT. All right, so I've skipped now. We've done the treatment, let's say, and this is the last imaging. After you've injected the Y-90, you can get a Bremstrong scan, which is basically a planar image. But people are also moving to PET CTs or SPECT CTs, because again, we are injecting our microspheres. We don't necessarily have any power of where they really distribute other than the blood flow. And so where we've been limited is how well we're actually radiating these tumors and actually getting dose maps, which radiation oncology is very good at doing, where they can circle and they can say, this is how many gray this area got. We haven't gotten there. And so that's where we're heading now, because doing PET CTs or SPECT CTs after our Y-90 injection, we can then get dose maps off of that. And then we know what radiation these tumors have gotten, an area of growth. And then lastly, you've treated the patient, they've went home. I usually get imaging about 4 to 6 weeks after Y-90, although some people wait 3 months because the radiation does take some time to have a full effect. I like to see patients sooner. I do it also like in the same time frame as ablation and TACE. And really you're assessing patients' side effects, how well they did with things, and then the tumor efficacy. And again, you want to get good imaging, triple phase CT or MRI, or if you got a PET CT before, maybe getting a PET CT after. And again, you see that FDG avidity, which then would hopefully go away, which is actually maybe is more sensitive than the arterial enhancement of the tumor. All right, so in the last couple minutes, I'm going to go over some cases just on the steps. And so this was a typical patient, 84-year-old female who was dealing with metastatic colorectal cancer. And the standard of care now for metastatic colorectal cancer is systemic chemotherapy. Even if it's in the liver, there was a large study performed where they gave systemic chemotherapy first line with radioembolization versus systemic chemotherapy alone. And we did see radioembolization had a good treatment effect. There was actually progression-free survival of 8 months. So by giving radioembolization, those tumors in the liver did better. However, when they looked at the overall survival did not change. So based on that study called the Surflox trial, we don't necessarily recommend radioembolization first line. That being said, this is the kind of patient we might see, in that chemotherapy has a lot of side effects. So this patient was started on, standard of care FOLFOX and Avastin. She's 84. She's dealing with mucositis, neuropathy. They start dose reduction, and basically she's done with chemotherapy. But her real issue is liver tumors. And so she was referred for radioembolization, basically stopping chemotherapy and just coming for radioembolization. So here's the images, and you can see the right lobe is predominantly tumor. And so we've kind of assessed that. We get our tumor volumes off of this. And she also had a PET CT, and you can see the very avid tumor involving mostly her right lobe of her liver. So we brought her for mapping angiography. You can see the catheter from a radial approach in the celiac artery. We have the left gastric artery. We have the celiac artery. We have the pancreatica, dorsal pancreatic here, which extends into the pancreatica magna. We have the proper common hepatic, GDA, proper hepatic, and now you see this little branch coming off here. That is the right gastric. So the right gastric is coming off the proper hepatic artery, and then we have a normal left hepatic artery, and there may be a middle hepatic artery and a right hepatic artery branches. So very typical anatomy. So her liver tumor, you saw, was kind of involving the right and extending to the left. So the plan actually was to treat whole liver radioembolization. So if I was going to do that from a proximal administration, I'm probably going to plant my catheter about here. So I'm going to be worrying about the right gastric artery and maybe the GDA. You know, this is a little bit older case. Now I do worry about these small supraduodenal branches that come down. So if I was going to treat whole liver, I might actually split my dose into a right lobe, do a right lobe infusion, and in the same day, take that microcatheter out, put a new microcatheter in the left, and then inject the left lobe dose. But anyways, this one I was planning to do a whole liver treatment, and you can see the tumors are vascular. And we do a portal venous phase always to show portal venous patency when we're doing these angiograms. So here now we've selected that right hepatic artery, and you can see these very typical gastric branches with then anastomose up to the left hepatic artery. And we have coiled now the right gastric artery. Then we select the GDA, and we coil the GDA. You want to coil up to its origin as well as possible so that it thromboses up to there, because you can have small branches even on the top of the GDA, which again supply the duodenum. So here was after we've coiled the right gastric, we've coiled the GDA, and you can see we've supposedly skeletonized the liver arteries, and we can inject our MA from here. Here's another angiogram from that. So we put the microcatheter right there. We see the left and the right. So we inject our MA. She goes for her SPECT CT. You see the tumors uptake the MAA, and the lung shunt is 8%. So we are not worried about lung shunting for radiation pneumonitis in this situation. So she comes back about a week later. I try to space the mapping and the treatment out a week. You don't want to wait too long in between. And we've put the microcatheter now back to where we injected the MA. And at this point, we gave 51 millicuries of resin Y-90. 6 weeks later, we see the tumor we had a PET CT before, we get a PET CT after, and you see the avidity has decreased significantly. Now, it's not completely gone. Again, these are palliative treatments. We have good situations where we really treat well, but this tumor did come back over time. But this was like a nice, single treatment, very limited side effects, and before and after, you can see it helped. All right, one last case. This is a kind of tumor type that we treat a lot, which is hepatocellular carcinoma. This is a patient that I first met in May of 2015. You can see there's tumor thrombus involving the right portal vein here. The tumor is inferiorly here, and his AFP, alpha fetoprotein, is 1700, which indicates this is an aggressive HCC. Standard of care with portal vein invasion is actually systemic, but the systemic treatment options were not good at that time. They're improving. So this patient came for radioembolization. So we came and did the mapping, and here we have our catheter here in the common hepatic artery, and you can see the tumor is hypervascular down here, and you start to see probably some portal vein opacification here. So that tumor thrombus is actually taking up some of the contrast, which will hopefully then be the radiation beads and will radiate that tumor that was growing into the portal vein. So now we've threaded our microcatheter here onto the right hepatic artery. We've coiled the GDA. In retrospect, did I need to coil the GDA? It's such a far ways back. You could probably leave it alone and watch as you infuse, and you would not be worried about reflux, but that was our first vessel of reflux. We coiled the GDA. We gave the MAA. Again, you see uptake in the portal vein as well as the tumor. And we brought him back about a week later. We came from transradial approach. We put it out into the right hepatic artery, and we gave a lobar radiation dose of 35 millicuries. And this was his follow-up. You can see now the tumor is basically shrunken down. The portal vein has also shrunken down. And this was about 3 months later, and his AFP has dropped significantly. And then I followed him actually over the years. And you can see a year later, his AFP now has dropped to 1.5 and the tumor has shrunk to basically nothing. And then again, he never had any recurrence, although he did have some recurrence in the last year, I would say, but over about 3 years, this tumor shrunk down to nothing with one single treatment treatment dose. So a good response. So it's 1 o'clock, so we'll just I'll conclude there. I would say radioembolization treatments are growing. It's something we weren't doing as much of, but there's been a lot of good data, patient awareness, and insurer awareness, and it's a very good treatment because the side effects are really minor. It's a palliative treatment, but sometimes it's worth trying because I do see fatigue, maybe I see some pain, but overall, compared to the chemotherapies these patients are on, they tolerate it very well. Patient selection is very key, and you want to make sure you're doing longitudinal care. It's very important that we're taking charge of our side effects and taking care of these patients. It is a multidisciplinary treatment. Also, there are places that have radiation oncology involved. There are places that have nuclear medicine involved. There are medical oncologists involved, surgical oncologists. And so it's a lot of times just kind of being a part of a team, and then you are able to provide your expertise. All right, thank you. Thank you very much for listening today.
Thank you so much, Dr. Ganguli. We really, really are grateful for your time and your talk. Thank you for all the attendees. Again, we'll pick up next Tuesday and Thursday. Tuesday's topic will be radiology leadership in that space, and on Thursday we'll be doing abdominal imaging. So we hope to see you then. Be well. Have a great weekend.